Now, part C, spontaneous ventilation in the normal, healthy patient with normal respiratory system mechanics, normal cardiovascular system physiology. We talked about what happens when your lung volume increases in part A, and that is you tend to have a compressive effect of the abdominal and pulmonary venous capacitance beds, which tends to augment venous return as a function of your baseline volume status. And it also, the increase in lung volume tends to affect right ventricular afterload predominantly, depending on how high above functional residual capacity you go. And then we talked about in part B what happens with a decrease in intrathoracic pressure, and in the young, not necessarily young, but in the normal healthy patient, this tends to increase your right ventricular preload, which then tends to have some diastolic interdependence effects on the LV, and there also tends to be a very mild, minor, probably insignificant increase in left ventricular afterload with normal decreases in intrathoracic pressure. So when we put these two things together, we get spontaneous ventilation, which is here. These guys we'll be talking about in the subsequent portions of this chapter. But spontaneous ventilation is this portion of the Venn diagram, and that is the increase in lung volume we talked about in part A, and the decrease in intrathoracic pressure we talked about in part B, and sort of how it relates to this Mueller maneuver, or the mini Mueller, which would be analogous to a normal inspiratory event. So intrathoracic pressure decreases with the spontaneous inspiratory effort. And as we see from the Campbell analysis, the pleural pressure drops as a function of your lung compliance, lung volume, flow and airways resistance, as we talked about extensively in Chapter 1. The degree to which the pleural pressure decreases, I've alluded to this before, the degree to which the pleural pressure decreases through the thorax is not uniform. It tends to decrease the most near the diaphragm, and the pleural pressure near the pericardium tends to be a little bit higher, and this may reflect compressive effects from the lungs, as the lungs, mostly from the lower lobe expansion, maybe potentially compressing the pericardium. But during spontaneous ventilation, it can be accepted physiologically that the intrathoracic pressure, and intrathoracic pressure is kind of an umbrella term that I use to refer to pleural pressure, the juxtacardiac pressure, which is the pressure right around the heart, pericardial pressure, that they're all decreasing. And the drop in ambient pressure has important effects on biventricular loading conditions. So also during spontaneous ventilation, lung volume increases, and therefore the effects upon the cardiocirculatory system can be viewed as a summation of both the effects of a decrease in intrathoracic pressure and an increase in lung volume. So what happens with spontaneous ventilation to the right ventricle? Well, from the Campbell analysis, which is again on the z-axis, on the x-axis here is pleural pressure, 0 is atmospheric pressure, above atmospheric pressure, below atmospheric pressure. This is the Campbell diagram. Pulmonary elastance, and this is normal. Resting chest wall elastance, and this is normal. This depicts the dynamic aspect of intrathoracic pressure and the pressure that must be dedicated to overcoming airways resistance and flow during an inspiratory effort. This is your intrathoracic pressure, as we've seen, at functional residual capacity. And as you take a spontaneous inspiratory effort, your intrathoracic pressure falls and your lung volume or thoracic volume increases. So that was what happens in the Campbell analysis. So let's superimpose the Guyton analysis and see what it does to the right ventricle. Well, again, this is intrathoracic pressure at FRC, which is depicted as the x-intercept of the cardiac function curve, and the reasons why we've already talked about. This is the pressure, the intraluminal pressure, or the pressure within the right atrium or the right ventricle at end diastole, that you would measure with your triple lumen catheter, for instance, and it's measured here. And then the distending pressure across the vascular wall is the pressure within the right atrium, or the end diastolic right ventricular pressure, less the pressure outside of the vessel. So you can think of that as the pressure distending the myocytes. And typically, as I've mentioned before, we know this pressure. We can measure this via a fluid-filled catheter placed into the patient's jugular vein, say, for instance, as I talked about in Chapter 5. But we're typically ignorant of this pressure, so we don't really have it. When we're measuring the pressure, the right atrial pressure, the CVP, we actually don't have a true knowledge of its distending pressure without knowing the intrathoracic pressure. We typically measure the pressure at end expiration because that's when intrathoracic pressure is closest to atmospheric pressure. And remember, the fluid-filled catheter by which we are measuring the central venous pressure is referenced to atmosphere. So that's why we do this. We make this pressure at end expiration. But if your intrathoracic pressure is quite low, you're going to significantly underestimate the true distending pressure of the right atrium and right ventricle. So you inspire along your Campbell diagram here. At the end of your inspiratory effort, your new intrathoracic pressure is represented here. The right ventricular cardiac function curve shifts leftward relative to the systemic venous return curve. Remember, the systemic venous return curve is essentially defined or created by the venous return from your abdominal splanchnic beds mostly, or I shouldn't really say your splanchnic beds, but the abdominal venous capacitance beds, or your venous capacitance beds in general, a large portion of which lies within your abdomen. And that's essentially atmospheric pressure. So you tend to augment the distending or filling pressure of the right heart, and cardiac output tends to increase, as we've seen. So RV preload is facilitated, but to a certain extent, as we talked about, RV afterload tends to increase a little bit as a function of the increase in curvature of radius of the RV. But also in spontaneous ventilation, as we saw, your lung volume is increasing. So in addition to just the increase in afterload that you get through distension of the RV, which again is a function of the decrease in intrathoracic pressure and your baseline volume status, because that's going to determine the distending pressure of the RV. The increase in lung volume tends to further minimally elevate the afterload of the RV, so the right ventricular cardiac function curve might shift down and to the right just a little bit as a function of the increase in your pulmonary vascular resistance from the increase in transpulmonary pressure. But again, we have to also remember that the increase in lung volume is decreasing the capacitance of the abdominal vascular or the abdominal venous capacitance beds. And that functionally shifts your venous return curve rightward by increasing your mean systemic pressure. And again, I've kind of drawn a couple of extremes here, but whether or not venous return is essentially maintained or increased will depend on your baseline volume status. So this patient here might be hypervolemic. This patient here might be very hypovolemic. And in the normal healthy patient who's quote-unquote euvolemic, there might be, or there will be, a slight increase in your overall venous return. So that would tend to augment your cardiac output just a little bit. So I haven't drawn it here, but if your cardiac output, or the operating point of your cardiovascular system, again, the operating point typically refers to the point at which the venous return and cardiac function curves intersect. If that were drawn here, your distending pressure will have increased and your cardiac output will have increased as well. The effect of lung volume, as I mentioned, on venous return depends on the pre-existing volume status of this patient. So what does spontaneous ventilation do to the left ventricle? Well, if we talked about in the section on the decrease in intrathoracic pressure, as you drop your intrathoracic pressure, you tend to preload the right atrium and the right ventricle, and the increase in volume, the increase in the right ventricular end systolic volume tends to impair the LV lusitropy, which is kind of like a fancy way of saying the relaxation properties of the left ventricle, or its compliance during inspiration. And this results in a small shift in the LV function curve, which tends to decrease your cardiac output. And this is probably the mechanism of the normal decrease in left ventricular output during inspiration. The increase in intrathoracic pressure from the increase in lung volume may also increase the left ventricular afterload relative to the intra-abdominal compartment as described above. Previous slides. While the decrease in intrathoracic pressure relative to atmospheric pressure technically shifts the left ventricular function curve to the left, the pulmonary veins are exposed to the same intrathoracic pressure, so the cardiac function curve and pulmonary venous return curve would tend to shift to the left together. Now, this is a very important point. I don't animate this, at least in this lecture, and I do this for simplicity, but it's a very important point. I kind of have, there's one slide in Chapter 7 where I've animated this, and it's the slide, if you're curious to see it, it's in the section where I'm talking about measurement of the pulmonary artery occlusion pressure and how increases in intrathoracic pressure affect your pulmonary artery occlusion pressure, and the same reasoning would apply to a decrease in intrathoracic pressure. That is, if you are measuring, say, your wedge pressure, your left, as an estimate of your left atrial pressure, if you were to inspire, you would see that the relative to atmosphere, which is the reference point for your pulmonary artery catheter, if you were to inspire, the wedge pressure would decrease. But that is not, that is not the same physiology that occurs to the right heart when you inspire. When you inspire in the right heart, the right ventricular cardiac function curve shifts leftward relative to systemic venous return because the right heart lies within the thorax, whereas the venous capacitance beds that determine systemic venous return lie outside of the thorax, and they are exposed to, for all intents and purposes, atmospheric pressure. That is not true for the left heart, and clearly the pulmonary veins, which are determining pulmonary venous return, are exposed essentially to the same intrathoracic pressure as the left heart. So in effect, with a decrease in intrathoracic pressure, the pulmonary venous return curve and the left ventricular function curve would shift leftwards in tandem. But I do not animate that. I do not animate that in my talks, in my slides, because it would just be very difficult to animate, and I think it would be more confusing. So I leave them stationary, but that's a very, very important principle to understand. Again, if you're curious on how they shift in tandem, watch Chapter 7. I don't know what part it is, but it's the slides on the pulmonary artery occlusion pressure, measurement of pulmonary occlusion pressure, and the transmission index. So they remain static, just for simplicity. As lung volume increases above functional residual capacity, pulmonary venous capacitance decreases. So if you want to remind yourself what that means, go back to the first part of this chapter, Chapter 3, Part A, and look at that slide on what happens to pulmonary venous return as the transpulmonary pressure is increased above functional residual capacity. So the venous return curve can shift to the right relative to the left ventricular cardiac function curve. And the degree to which this happens depends on the zonal characteristics of the lung. Remember, the greater the West Zone 3 physiology, as you increase lung volume, there will be a greater shift in the pulmonary venous return curve rightwards relative to the left ventricular cardiac function curve. So spontaneous ventilation in the left ventricle. Again, spontaneous ventilation on that Venn diagram is a decrease in intrathoracic pressure and an increase in lung volume, so you have to summate those effects on the cardiocirculatory system. And on the Campbell diagram, which I've depicted in the z-axis here, on the x-axis here you have intrathoracic pressure as measured in centimeters of water here, or your pleural pressure. Again, this point marks 0 or atmospheric pressure. These are subatmospheric pressures. These are pressures above atmosphere. Functional residual capacity, you inspire to a new tidal volume, you've dropped your intrathoracic pressure along the x-axis, and you've increased your lung volume along the z-axis here. So let's do that again now with superposition of the right ventricular cardiac function curve. So this is the RV function curve. This is systemic venous return, we'll say. You inspire, the cardiac function curve traces, as we saw in part B, the decrease in intrathoracic pressure. You've increased the distending pressure, the transmural pressure, the pressure, the intraluminal pressure less the extrathoracic, or the extraluminal pressure, I should say, which is the distending pressure of the right atrium and the right ventricle. So this has increased. Your cardiac output has increased. Again, I'm talking about the LV, so why am I talking about the RV? Well, it has important effects immediately, and because of parallel effects, that is parallel effects I may refer to often. Parallel effects, I'm referring to ventricular interdependence, and series effects, which is a few cardiac cycles later when the RV output meets the LV. Okay, so now this becomes a ghost, and now this venous return curve is pulmonary venous return, and I'm going to start talking about left ventricular cardiac function. So the increase in end diastolic right ventricular volume causes a brief decrement in LV diastolic dysfunction. So if this is your baseline left ventricular cardiac function curve, again, this is now pulmonary venous return. This is the operating point of the left ventricle in pulmonary venous return. That distension of the RV during inspiration causes a very small decrease in your left ventricular compliance by ventricular interdependence, and very temporarily decreases your your left ventricular output. Again, that's immediate effect, and the cause of pulses, cause of the, I shouldn't say pulses, I keep saying pulses. That's the cause of the normal inspiratory decrease in your left ventricular output. Okay. The lower intrathoracic pressure raises the left ventricular afterload. And again, I want to stress that this chapter 3 is all about the normal situation. What's happening in the normal healthy patient? Well, in the normal healthy patient, the drop in intrathoracic pressure of 3 to 5 centimeters of water, which is, a few millimeters of mercury, isn't really going to profoundly increase the transmural wall stress of your left ventricle and aorta during systole. So this effect is essentially zero, even though I do illustrate it here as a small drop in your left ventricular cardiac function curve. I want to emphatically note that it's a minimal effect in health. Okay. But the increase in lung volume, as we saw in part A of this talk, tends to shift the pulmonary venous return curve relative to the left atrium based on the pre-existing volume state of the lung. So if the lung is all soggy and underwater and all the pulmonary vessels are all plump in West Zone 3, well, increasing your transpulmonary pressure, increasing your lung volume is going to squeeze blood out of the lung and essentially bolus your left heart. Whereas if your lung is empty, well, it's going to kind of have an opposite effect. You may actually increase the pulmonary venous resistance as your transpulmonary pressure supersedes your pulmonary venous pressure and causes those vessels to collapse. So again, the effect on the operating point of your left ventricular cardiovascular system, I guess I should say, the operating point will go up or down depending on both the volume state of the pulmonary capacitance vessels as well as the degree to which lung volume increases. So that's kind of spontaneous ventilation in the LV. Again, this is modeling both series and parallel effects on the LV, the parallel effect being ventricular interdependence, the series effect being the change in pulmonary venous return. And I do want to stress, again, like I talked about a few slides ago, that during an inspiratory effort, this drop in intrathoracic pressure that we saw on the Campbell analysis, really all of these curves, and that is the cardiac function curve and the pulmonary venous return curves, all of these curves in tandem would be shifting leftwards with the drop in intrathoracic pressure. Okay, but I'm not depicting that just for simplicity. So you would measure a drop in your wedge pressure, say if you were measuring this with a pulmonary artery catheter, when the patient inspired, But again, that's an artifact of measurement. The venous return curve, because the pulmonary veins and the left ventricle are exposed to the same drop in intrathoracic pressure, they're not really changing relative to themselves as a function of the change in intrathoracic pressure. They are changing relative to themselves as a change in the pulmonary venous capacitance beds, which will extrude blood out of the lungs as the lung volume is increased. So that was spontaneous ventilation. We're now going to move on to the right half, or the anatomic left half of the Venn diagram that we've been looking at, and we're going to talk about just how an increase in intrathoracic pressure without an increase in lung volume tends to affect the cardiocirculatory system. And then we will, after that, go on and talk about an increase in intrathoracic pressure and an increase in lung volume, which, as you know, is a mechanical breath.